Good afternoon to all the August audience, respected chairpersons, moderators. My first talk on this STEMI update, culprit only versus complete revascularization, strategies to treat multivessel disease in STEMI. Now, this topic or this area in interventional cardiology has been an area of controversy since long. We know that approximately 50% of the patients who are presenting with STEMI, they have at least one other vessel having a significant, at least more than 50% stenosis in a non-culprit artery. And presence of obstructive lesions in a non-culprit artery has been historically shown in the scientific literature to be associated with a worse short and long-term outcomes. Now, whether these non-culprit lesions along with the infarct-related artery needs revascularization has been controversial. Old guideline recommendations, they advise against non-culprit vessel PCI in the absence of any spontaneous myocardial ischemia or intermediate or high-risk features and invasive assessment. Now, the question is that compared with the culprit-only percutaneous PCI, is a strategy of complete revascularization with multivessel PCI can be associated with a decreased cardiovascular mortality in STEMI, and whether the association of fractional flow reserve or angiography-guided complete revascularization approaches are used. Now, as you know, the present guideline recommendations, the ESC 2017 guideline, after a series of studies, namely starting from the PRAMI study, the DYNAMIC 3 Primality, and the culprit trial, they have upgraded the recommendation of complete revascularization in PRAMI patient from class 2B to class 2A recommendations, and they are based on mainly on these 4 trials. We'll briefly go on these 4 clinical trials. Now, which has shaped this guideline recommendation, it mainly is driven by these 4 trials: the PRAMI trial, the complete versus the lesion-only primary PCI, or the culprit trial, the DYNAMIC 3 Primality, which is an FFR-guided trial, and the COMPARE acute trial. All these studies has been published in and around between 2013 to 2017. Now, in these studies, if we dissect the studies closely, we'll see that the PCI of the non-infarct artery was done either during the index procedure itself while opening the IRA in PRAMI and in COMPARE acute study. It was staged during the same hospital admission in DYNAMIC 3 Primality, and anytime before discharge, which can be on the day of index procedure or before discharge anytime in culprit trial. Now, indications for PCI non-IRA was angiography-guided lesions with more than 50% stenosis in PRAMI, more than 70% stenosis in culprit. So in these 2 trials, it was primarily angiography directed and FFR-directed revascularization in DYNAMIC 3 Primality and COMPARE acute. It was seen that these 4 randomized clinical trials, first is the PRAMI trial, which was done between 2008 and 2013 in 5 centers in the UK. Infarct-related PCI versus the other group was randomly assigned either conservative management or the non-infarct-related PCI. It was seen that the patients with STEMI and multivessel CAD undergoing infarct artery PCI, preventive PCI in the non-infarct artery was with a major stenosis. It significantly reduced the risk of adverse cardiovascular events as compared to PCI, which was only limited to the infarct-related artery. The culprit trial was a trial with similar design, where in one arm, the patients were stratified based on infarct location and symptom onset, and the primary composite was all-cause death, recurrent myocardial ischemia, or repeat MI, non-fatal MI, heart failure, ischemia-driven revascularization within the next 1 year. And it was seen that in the primary composite endpoint, it occurred in 10% in the complete revascularization group versus 21% in the infarct-related artery only revascularization group. So the complete revascularization group fared significantly well, and it was statistically superior seen in the complete revascularization, and the trend towards benefit was seen very early even after the complete revascularization. The curve diverged and achieved a point of statistical significance even only within 30 days after the procedure. So it was quite a superior trial, though neither of the primary endpoints was statistically superior, but all showed a trend towards superiority, which culminated totally into a statistical superiority. So the conclusion was that in culprit trial with a multivessel disease, complete revascularization possibly lowered the rate of composite primary endpoint at 12 months compared with treating only the IRA. Another similarly designed trial was a Dynamic 3 primality, but the differentiating factor in Dynamic 3 was that these revascularization in the non-infarct artery was guided by the FFR values, and the follow-up was longer for up to almost 2.5 years. Events comprising of the primary endpoint was recorded in 22% of the patient who has PCI of only the infarct-related artery versus only 13% who had complete revascularization. So this study also established the superiority of total revascularization or complete revascularization post-MI. Dynamic 3 primality, a CMR sub-study analysis showed, however, that complete FFR-guided revascularization who were enrolled into this complete revascularization, though the primary endpoints was reduced, but MR-guided CMR-guided final infarct size LV function or remodeling was not significantly improved compared with culprit-only PCI. So there was a slight, contentious issue. Now, interpretation in the light of Dynamic 3 primality was that these effects were primarily driven by fewer repeat revascularization and not hard endpoints like cardiovascular death, because all-cause mortality and non-fatal infarction did not differ between the groups, that is infarct-related artery and complete PCI. Another big study was done by Hamza et al. That primarily studied the diabetic patients with MI and which replicated almost the similar results, that diabetic patients who underwent a complete revascularization in the same sitting or during the index hospitalization possibly fared better in terms of primary endpoints of death, MI, repeat revascularization. Compare Acute trial was a similar trial that was published in 2017. It was also an FFR guided trial. FFR was performed in both the groups, and the uniqueness of the trial was that even after performing FFR, both the patients and the cardiologists were unaware of the findings of the FFR, and they were randomly assigned between the trial group and the control group. Primary endpoint was similar, all-cause death, non-fatal MI, and revascularization, and results were seen. The primary outcome occurred in 23 patients in the complete revascularization and 121 patients, which were statistically equivalent to 8 versus 21 events per 100 patients. So the group which received complete revascularization FFR guided fared significantly better than the patient who underwent only infarct-related artery PCI. So the conclusion was similar as it was drawn from the PRIMID trial and the Dynamic 3 primality. Prague was one of the trials similarly designed. However, it diverged from the primary culprit. That Prague trial, it was published in the similar trial time. It failed to show any significant benefit in the patients who underwent complete revascularization. Some points has been, proposed by the investigator himself regarding the design of the trial, which might be leading to this trial being a negative trial. And the landmark trial, which was published in 2019 NEJM, was a complete trial. Everyone was waiting for the trial because it was a large trial, adequately designed and powered to study the hard endpoints of mortality benefit in this subgroup. And it conclusively proved this complete trial. And in complete trial, important to note was that the staged PCI was done either during hospitalization or within 45 days after hospital discharge. So a time was provided after the patient was being discharged. Exclusion criteria was an intention before randomization to revascularize a non-culprit lesion, a planned surgical revascularization in previous CABG. They were excluded from the study. Other patients, they were incorporated. Primary endpoint was CV death and new myocardial infarction. Secondary endpoints were almost similar among the other studies. And you can see that cardiovascular death, it was the first trial to show that the CV death was significantly improved, the first, or myocardial infarction in this complete trial. So complete revascularization was associated with a reduction in the cardiovascular death and MI, and it was the first trial to show conclusively that it improves the CV mortality also without any significant increase in major bleeding or contrast-induced nephropathy. So these, in short, is a summary of all the trials that studied these infarct-related artery, revascularization versus the complete total revascularization in the MI patients. And more or less, these studies has pointed towards a beneficial effect, be in terms of reduction in the target vessel revascularization, ischemia-driven revascularization, and even mortality benefit in the complete trial over the last 1 decade or so. This is a meta-analysis of all these trials. Almost similar study has been similar results. FFR versus angiography-guided non-culprit lesion PCI, because we have seen that FFR was used in compare acute and dynamic 3 primality, whereas culprit and PRAMI was driven by angiography-guided revascularization. However, the meta-analysis showed that there was no significant difference when revascularization was done either by angiography-guided visual estimation or by FFR. There was no evidence of any heterogeneity. Same was seen in terms of same sitting or index procedure revascularization or a staged approach. That is whether the non-infarct artery was opened in the same sitting, depending on the operator's experience and expertise, or whether it was staged procedure. The result was similar. So the clinical caveats, one important thing to keep in mind is that in prospective study, we know that in natural history of atherosclerosis, nearly 50% of the events, future cardiovascular events, it occurred in the non-culprit bystander lesion. So in no way they can be considered as a, benign lesion. And interestingly, most of the culprit lesions who are responsible for the future events, they are usually angiographically mild at baseline, or the vulnerable plaques can be mild. An important subset, those were not included in these trials, were the subsets of cardiogenic shock, which was tried because these do not apply to patients in cardiogenic shock, which was tried or tested in culprit shock trial. Culprit lesion versus PCI versus the multivessel PCI and cardiogenic shock, which showed, however, entirely the opposite result, that showed increased mortality of the patients who underwent multivessel PCI compared with culprit vessel only PCI in acute MI with cardiogenic shock in both short-term as well as in long-term basis. So in patients with acute MI, whether STEMI or non-STEMI, in culprit shock, both even non-STEMI patients or NSTMI patients were also included with cardiogenic shock, and significant reduction in the primary composite of all-cause death and severe renal failure requiring renal replacement therapy was observed in culprit lesion-only strategy rather than with complete revascularization during an index event, with an very significant 8.2% absolute reduction in mortality within next 30 days. So in a nutshell, we can understand that MI with shock is possibly an entirely different ballgame, and various other factors like operator's expertise, dye usage, patient's hemodynamic status, renal function comes into play. So depending upon all these trials in 2017 ESC guidelines, they upgraded this complete revascularization indication from class 3, that is harm, to straight away class 2A, that is may be beneficial or likely to be beneficial in MI patients, mainly based on these 4 trials, that is PRAMI, dynamic 3, culprit, and compare acute, which has been further substantiated and consolidated based on the, this complete trial. Thank you very much.